We have a minute to go live, sir, now. If any of the faculty log out because of their internet connection or any other problems, please log in again and put a chat message to me so that I can make you a co-host again.
Okay.
Sure.
So sir, it is 5 o'clock. Should we start? We have 73 participants with us and more will be joining.
So we can start, I think.
Yes, sir. So with your permission, sir, I will announce and I'll take a minute more today.
Okay.
Good afternoon and thank you everyone for joining today's webinar. My name is Dr. Amit Borse, a Senior Product Manager with IVA, a division of MCure Pharmaceuticals Limited. MCure is a pioneer in the field of gynecology and IVF. Today, let me share a very proud moment for us. This is our 100th webinar in this COVID times. And as I was saying previously, the knowledge base which has been generated due to this time, a very positive side of COVID, has been accumulated with us, and we will soon be launching IVA, IVF Virtual Academy, with a compilation of 100 webinars from pan-India, national, international, and regional level doctors. I will take this opportunity to thank all the doctors, gynac fraternity and embryologists to help us to do this task unconditionally. I'll also thanks my team to support this cause. We here will again thanks Dr. Ved Prakash sir. Dr. Ved Prakash sir has given us an opportunity in a row to conduct this webinar to be the academic partner. Dr. Ved Prakash sir is the lab director of South End Fertility and IVF Center, Delhi, a vice president for Academy of Clinical Embryologists, India, and he is the founder director of ihera. Sir, thank you very much for giving us yet another an opportunity, and we wish to get your support hereafter as well. So may I now hand over the session to you, sir?
Thank you, Dr. Bose. Thank you for the nice introduction. Can you please stop sharing? Yeah. I want to share my screen now. So, good evening, everyone. On behalf of ihera and MCure, our academic partner, I welcome all of you. As you know, ihera is continuously doing webinars to share the knowledge, and it is totally free. And today we are going to discuss on fertilization strategy in ART. It is second part of last webinar. So here we have two eminent speakers, Dr. Rajvi Mehta and Dr. George Lipres from Australia. And there will be one panel discussion on insight of fertilization failure. Dr. Swami and Dr. Saroj Agarwal going to speak, moderate that session. So to moderate first session, we have Dr. Rahul Sen. Just Dr. Rahul Sen is MSc PhD, currently working as Chief Clinical Embryologist in Vasundhara Hospital Limited, Jodhpur, Jaipur, Rajasthan. He is an executive member of ACE, executive member of ISAR, and organizing secretary for Embryology ISAR 2018, held at Jaipur in December 2018. He is a member of ISAR IFS ACE ASHRAE and organizing committee member of National Conference IFS ISAR. And second moderator is Dr. Pankaj Kaingde. He is PhD in reproductive biology. Dr. Pankaj is consultant embryologist with over 11 years of experience in human-assisted reproductive technology and research. He has a distinction of conducting thousands of ART cycle. He has total 10 international indexed publications to his credit and few more in pipeline. He has authored one book chapter on surrogacy and IVF. So by this, I hand over to Dr. Rahul Sen to conduct the next session.
Thank you, sir, for the kind introduction. A very warm good evening to everyone. On behalf of ihera, I, embryologist Rahul Sen, welcome you all in this academic online meet. This academic online meet on revising fertilization strategies in ART. And for the first talk, as a student, I would like to introduce the speaker of the first session, that is, and it gives me a proud privilege to welcome Dr. Rajvi Mehta ma'am. She needs no introduction, is a very well-renowned personality in Indian embryology.
Rahul, excuse me, Rahul,
Yes, sir?
it is Dr. Rajvi Mehta, CV is not there. You please.
Oh, just a second. Yeah.
Yeah. Now.
So it gives me a proud privilege to introduce the first speaker of the session, Dr. Rajvi Mehta ma'am. She's very well-renowned, proud personality in the Indian embryology. Ma'am has worked in the field of ART over 3 decades and being one of the very first in the country to get PhD in human IVF under the great Dr. T.C. Anand Kumar sir. She has published papers in various reputed journals like Human Reproduction, RBM Online, and contributed dozens of chapters in various publication houses. And ma'am has been invited speaker for many conferences like IIFS, Iran, and ASHRAE, Germany. Ma'am is currently working as an academic consultant to Cooper Surgicals and scientific consultant to Trivector Biomed. She is also an executive member for Academy of Clinical Embryologists India. She is in charge of IFS SIG on holistic medicine and a teacher in Iyengar Yoga for 3 decades. Ma'am, screen is over to you.
Thank you, Rahul, for the elaborate introduction. And at the outset, I would like to thank and rather compliment Dr. Ved Prakash and his entire team on reaching this milestone of the 100th webinar. I think it's quite an achievement, and I really congratulate the entire team for doing this. Well, the topic of my presentation is primarily going to be the role of oocyte activation in fertilization. And as embryologists, all of us dread when we reach day 1 and find that if there are embryo or if there's no fertilization taken place, it's quite a nightmare. Although it is not so frequent, but if and when it happens, it's something which we all dread. And we do know that this conversion of a mature oocyte to PN, whether it is due to after an IVF or after an ICSI, it is something which is triggered by sperm entry into the oocyte. Now, how often do we find total failed fertilization? And we know that it is not that frequent. It is just about 3% cases in IVF, and all the oocytes which have been exposed to sperm fail to fertilize. And that's also one of the reasons that many of us tend to directly go and do ICSI, because we don't want to face the trauma of total failed fertilization. However, even after ICSI, you find that there are at least 2 to 4% cases where fertilization fails. And that could be just that we have very few oocytes to start with, and it appears as total failed fertilization, but in reality, we have very few oocytes, or we have used non-motile sperms, and therefore we are not really sure of the sperm selected. The skill set, of course, that if there is a novice embryologist and there are problems with the technique itself, but there are 2 physiological reasons where we may not achieve fertilization. One is that after the sperm enters the oocyte, there's incomplete decondensation of the sperm chromatin. And in this balance of the cases, whether it is the oocyte fails to activate, and that is the reason we see a total failed fertilization. The last 2 are physiological reasons, and that is something which we are trying to figure out. What is oocyte activation? What exactly happens? And when it fails to happen, can we identify the cases where it does not happen, and how we can overcome this kind of a limitation? So if we look at the 2 physiological reasons, one is the failure of the sperm chromatin to decondense. Well, in cases, there are a series of reports which are shown on the right, where they have actually studied the oocyte which had not fertilized, and they found that in majority of the cases, the sperm chromatin had decondensed. So in 70%, 80% of the cases, the chromatin did decondense. So the failure of oocyte activation remains to be the reason why fertilization did not take place. Now, what exactly do we mean by oocyte activation? Now, what happens is that when a sperm enters the oocyte, or in ICSI, when we inject or the needle enters into the oocyte, the sperm has the oocyte activating factor termed, which is now clearly identified as phospholipase C zeta. And moment this phospholipase C zeta enters into the oocyte, it triggers the process of oocyte activation, which one would be the exocytosis of the cortical granules. So there is a movement of these cortical granules to the ulemma towards the ooplasma, which brings about changes into the zona, preventing polyspermy. The second thing is the oocyte, which is arrested in the metaphase 2 of meiosis, completes meiosis, and then we see the formation of the 2 pronuclei, and finally which leads the formation of the zygote. So basically all these activities are triggered by the entry of phospholipase C zeta into the oocyte. And when this activation doesn't take place, it could be either that the sperm does not have enough phospholipase C zeta, or there are certain oocyte factors by which the phospholipase C zeta does not act, and therefore we have failed fertilization. Now, if we are going to understand the association between PLC zeta and total failed fertilization, there were a couple of reports just earlier this year, and what they found was that in these are 2 different studies, both reported earlier this year, and in this case, patients who had total failed fertilization. And in all these cases, they found that there were biallelic mutations in specifically the gene encoding for PLC zeta. Now, if it was a missense mutation, in those cases, the level of PLC zeta levels in sperms was low. And in case it was a nonsense or a frame shift mutation, there was no PLC zeta, or the proteins that were formed following transcription and translation were truncated proteins. So all in all, it was found that it was mutations which had occurred in these patients, which led to the low levels of PLC zeta or total absence of PLC zeta, which in turn led to failed fertilization. And in studies done in mice, they found that whenever this mutation occurred in mice or were created in mice, they reduced the level of oocyte activation, clearly showing a strong association between PLC zeta and oocyte activation. Now, what does PLC zeta do? Basically, what it is found is that the whole process of oocyte activation is basically an interplay of calcium oscillation. So moment the sperm enters or the needle enters into the oocyte, within 10 to 15 seconds, there is a spike of calcium ions, and this spike lasts for 4 to 12 hours, but it is not static. So there are spikes which last for 20 seconds, then come down, then there's another spike, and these spikes last for about 1 to 5 minutes. Then there is a sort of a relatively silent phase, and again this oscillatory phase starts every 30 minutes to 1 hour. So basically it is understood that these calcium ions and these calcium spikes actually help in the migration of the cortical granules, and then as it comes to the end of fertilization phase or the end of the termination of oocyte activation, these amplitudes of calcium spikes start decreasing, becoming smaller and smaller, and then there is no. So basically, if there is insufficient calcium ion influx, also it was presumed that there could be altered oocyte activation. So what do these calcium ions do? So as I said earlier, these calcium spikes actually physically bring about the movement of the cortical granules. Now, what are these cortical granules? They are proteases, glycosaminoglycans, and peroxidases. And these start altering the ulemma and ooplasma, and on exocytosis, they alter the zona pellucida and prevent polyspermia. And then they do the subsequent features of oocyte activation, that is completion of meiosis and the formation of pronucleus. A thought has been put forth that when individuals who are on calcium channel blockers, that if they are taking this kind of a therapy, would it affect the calcium oscillations within the oocyte? That's a question that has been very aptly raised in this review by Hojnik and Kovacic, that this could possibly also affect. So it's an iatrogenic cause of calcium altering oocyte activation. Now, if you put it graphically, what really happens is that these calcium ions on the entry of the sperms and through the sperms, the release of the PLC zeta into the ulemma, this acts on the endoplasmic reticulum and leads to a calcium influx. Now, this calcium influx on one hand goes to the movement of the cortical granules, which I've explained twice already in this short span, And these cortical granules bring about an alteration in the zona, while at the same time, these cortical granules and this calcium influx plays a role in these formation of the pronucleus. So basically, one can see that any alteration in the PLC zeta or in the release of calcium ion would affect oocyte activation. So the question is that, is there some way we can trigger the calcium oscillation? Is there some way we can inject PLC zeta into the oocyte, whereby we can improve oocyte activation? So just summarizing in very, very simple terms, what exactly happens in oocyte activation? It is this basic physiological principle and this understanding by which we try to overcome total failed fertilization by artificially inducing oocyte activation. So what is artificial oocyte activation? Basically, this is something which has been done for nearly a decade, but it is still in an experimental phase. And what one tries to do here is that either there is failed fertilization after ICSI and we try to trigger it, or because the oocyte is sort of dormant in its state as it has not got fertilized, or we have a previous history where there is total failed fertilization and in the next attempt, one is attempting to do artificial oocyte activation. So one attempt is to just alleviate the intracellular calcium concentrations or try to mimic the oscillations inside. As I mentioned earlier, there have to be spikes. So it is not just an influx of calcium, but we need to get that frequency of the spikes to get mimic the endogenous situation. And this has been attempted in 3 different ways: by the electrical means, chemical means, and the mechanical means. And I must say that the mechanical means was something which was attempted by Thomas Ebner way back in 2004. And he did a randomized trial by injecting and putting the needle as close as possible to the other end of the oocyte. And he reported that in cases where there was previous failed fertilization, they managed to get fertilization. However, there have been no subsequent reports or any kind of further studies which talked about mechanical means of oocyte activation. The most popular remains to be the chemical means by introduction of ions, or it could be in introduction of phospholipase zeta, PLC zeta, and also electrical means have been used for artificial oocyte activation. Now, when we come to the electrical means of oocyte activation, there is a direct electric current which is applied to the oocyte, and this electric field stimulates the charged proteins to move to the plasma membrane, and therefore it creates pores. So basically, we are using electric current to create pores in the plasma membrane, and therefore there is an influx of calcium ions from the culture medium into the oocyte. The question that remains is that if in any technology we are trying to mimic the endogenous situation, then will this calcium influx would just lead to a spike? But how will it bring about that endogenous frequency of spikes and the drop every 20 seconds? So that doesn't occur in this case. And therefore, there is always a concern that to what level can we activate the oocyte with electrical means? Studies have been done. And in this case, electrical activation of oocytes was done after ICSI injection. And these were non-obstructive azoospermias patient or with severe OATs. And this was a sibling oocyte study. And in this study, they found that if they did only ICSI, and they have used a large number of oocytes, they had a fertilization rate of just about 64% and total failed fertilization of 5%. However, when they did electroactivation with ICSI in this group, they did not have any total failed fertilization. However, the degeneration rate was slightly higher, and that can be understood because there would be a lot of standardization about the amplitude of current that is going to be used and how long. So there are many factors involved here. But especially in cases of severe OATs and non-obstructive azoospermia, where we are concerned about the quality of sperms that are being injected, it did seem to work. And then they went on to study the outcomes with artificial oocyte activation using electrical stimulus. And in this case, they have used round spermatids. And if you can see, these are the 4 different graphs here when they did not do any oocyte activation. This is when they did oocyte activation along with ROSI. This is when this is only aspiration along with electrical stimulation. And as you can see in the last, they do manage to get the spikes with the electrical stimulation. So they went on to show that yes, we can mimic the endogenous spikes in calcium with electrical stimulation and oocyte activation. And they have even reported healthy babies which have been born following the use of thing about 5 years ago. However, there are not many more reports with electrical stimulation. Now, of the chemical methods of activation, the most popular one in the early times has been the calcium ionophore, especially calcium ionophore 29173, which has often been used to artificially activate the oocyte. Strontium chloride is another popular kind of means for oocyte activation, and this has primarily been used in Iran and in some of the Japanese studies. Both these have reported healthy babies being born following the use of this method. However, I would say the more recent one and more physiological one is the use of PLC zeta, which was first reported in 2012. And considering that, if we have understood the physiology of oocyte activation and its role in fertilization, we realize that the use of PLC zeta is more synonymous or is as good as possibly better than using any kind of the other chemical agents. So in the initial studies which were done with mice oocytes, here what they did is they were trying to identify the optimum concentration of recombinant PLC zeta 1 injection into mice, and you can see different concentrations of PLC zeta that has been used and the number of oocytes that were injected, number of oocytes that got fertilized, represented with the presence of 2PN, and the number of embryos formed and the morula. So as you can see, in the absence of injection of PLC zeta, there was barely any fertilization and absolutely no embryos developed. However, as the concentration increased, they found that nearly the number of oocytes out of 64, nearly 45 of them fertilized, and out of those 31 embryos were formed and 2 developed to the morula state. So these were one of the earliest studies which showed that we could artificially induce oocyte activation. And then in another study, in cases where the ICSI had failed, and in 7 such patients who donated that oocytes which had failed, and then they subjected these oocytes to calcium oscillations. And again here, when they measured the calcium oscillations after artificial oocyte activation, again with PLC zeta, they found that they did detect calcium oscillation activities after the injection of PLC zeta. And remember, these were the oocyte which had failed with ICSI. And subsequently, when they went on to study whether these developed into fertilized oocytes, what they found was that out of the 16 donated oocytes, in 8, only PBS, phosphate buffered saline, was injected, and only 1 of them fertilized, that is just 12%. On the other hand, when they injected recombinant HPLC zeta 1, 5 of the 8 oocytes actually went on to fertilize. So this really shows that in cases where ICSI has failed, and if we talk of even total failed fertilization, either in IVF or ICSI, a 62% fertilization rate is indeed remarkable. But again, these were experimental studies in donated oocytes. Just earlier this year, there was a report, and most of this work on PLC zeta has been done by the Chinese groups, and these are located in different parts of China and not just from one part. And what they found was that they did a comparison of 1,261 ICSI cycles with only ICSI, and another 796 cycles where ICSI plus artificial oocyte activation was done. This was done with calcium ionophore. And they found that whenever they did artificial oocyte activation along with ICSI, they found significantly higher pregnancy rates as well as live birth rates. Also, the quality of blastocysts, the embryos obtained from patients with oligoasthenoteratospermia, and as well as unexplained infertility, they found better embryos and also lower miscarriage rates. So all in all, they go ahead to show that artificial oocyte activation in combination with ICSI did help. The only cases where it did not help was where there's primary ovarian insufficiency. And I said right in the start of my talk that we have total failed fertilization when we have a less number of oocytes. And that cannot really be attributed to any physiological reason as far as the oocyte concerned, but it's maybe more of reasons of poor ovarian reserve. So having said that, this is one of the most recent published reports, but this data has been accumulated over 4 to 5 years that has been presented. Now, what does it indicate? Should we go on for artificial oocyte activation? Should it be done in cases where after we have total failed fertilization, so in the subsequent cycle? What should be our strategy in utilizing this technology? And therefore, we generally, when we see a lot reports coming in, and very often these reports are ambiguous because different labs give different kind of reports. Secondly, in this particular case, people could be using different means for artificial oocyte activation. They could be using strontium chloride, they could be using calcium ionophore, or more recently PLC zeta. And depending on also when has this activation been done? Is it been done along with ICSI or after ICSI? If so, how much time between ICSI and this? So all these factors do play a role. And therefore, we try to get to some conclusion by looking at meta-analysis. And one of the earlier meta-analysis of 9 articles showed that there was some level of benefit with reference to the number of embryos or cleavage state embryos formed, as well as blastocyst formation. But then the level of evidence was very low, so they could not come to any conclusion. However, 2 years later, and both these are, mind you, are published in very reputable journals. And if you look at another report just 2 years later, they found that artificial oocyte activation with calcium ionophore treatment after ICSI did result in a significant improvement in fertilization, cleavage, blastulation, and implantation rate, and overall pregnancy and live birth rate. So this gives us a lot of hope to prevent total failed fertilization. The next question is, how should we jump into it? Should we be offering it to patients? Well, first and foremost, we need to realize that the current studies is highly variable because the methods used are very, very different. So we don't really know about it. Second thing is, it also depends on the quality of oocyte, the condition of the oocyte, the timing, and finally, the cause of failed fertilization. Now, the major issue that comes in with any technology that we introduce in ART is a balance between safety and efficacy. A short-term view would be the efficacy part. Yes, we did not get fertilization, we've got embryos and we've got pregnancies. But on the other hand, we do not know about how safe is it. What would be the long-term consequences or even immediate consequences of using this kind of technology? And there is always, as if a very difficult decision to be taken on whether we need to give more importance to safety or efficacy. And the question is that we cannot just be waiting for the safety aspects, because if we talk of safety, how long? Are we going to wait till the babies are born? Are we going to wait till we follow up the babies born and see how healthy they are? Are we going to wait till they become of reproductive age? Obviously, that's all going to be too late. So basically, we will need to kind of play a very tight, walk on a very tight rope, balancing safety and efficacy. As of now, there is very limited data available on the safety aspects. Fortunately, we haven't seen anything abnormal of the studies that have been done in Ghent, and also the reports of babies born in Iran. The children born, there has been no kind of a major birth defect, mental or behavioral status of these children. But we do realize that the children born are still too small for us to determine the long-term consequences. But nothing has come in yet to say that it is unsafe. But that does not mean that it is totally safe. And if we look at the efficacy, yes, as I've said, that the reports are very positive, that it is useful, but we need to balance between these two aspects. So to conclude, I would say that oocyte activation is a complex phenomena. It is not just the injection of calcium ions or the influx of calcium ions into the oocyte, but it is also the way that the spikes of the calcium takes place and subsequently leads to the completion of the second meiotic division and the formation of the zygote. Also, when there is no oocyte activation, in the current evidence shows that it is primarily due to the limited production of PLC zeta by the sperms. And therefore, if injection of PLC zeta into the oocyte can help prevent total failed fertilization in these kind of cases. However, we need to identify which patients would benefit. So maybe if one day we have kits or we have ways to measure PLC zeta levels in sperms, then we can identify those individuals, and maybe we don't need to wait for a failed fertilization and a subsequent cycle. We could directly apply oocyte activation. And as much as it is safe, so far, we don't really know the long-term consequences. And we also know that adding any kind of extra intervention in ART is going to add to our workload, to our cost and our stress of technology failure. So we need to be very cautious. As of now, for its routine use, we need to be very, very cautious. It's still in an experimental stage, so we can use it in caution. But yes, in the experimental cases, it could be used in certain kinds of cases where we do anticipate or we have experienced it in the past. So I thank you, and I hope I've kept up to my time. Rahul, I hope it's,
Yes.
yeah. So that's it. I'm open to any questions.
Yeah. Thank you, ma'am, for sharing this wonderful presentation on oocyte activation. Yeah, there are a few questions. Calcium ionophore activation is approved or still it is in under experimental phase?
It is being used in the clinical phase, but I would still call it to be an experimental. It is not something which should be advocated for routine use.
Okay.
Yeah.
So there was a paper, means a study mentioned by you in the presentation by Thomas Ebner.
Yeah.
He introduced few mechanical ways to, as a precautionary way to avoid oocyte activation, kind of means a failure situation.
Yeah.
So what can be those situation in particular?
See, actually in Ebner's study, which was way back in 2004, and I must admit that in 2004, the way ICSI was being done and the way we would say ICSI is being done now, there has been the number of skilled people and the way, the way it is done has definitely improved a lot in terms of the equipment as well as the technique. What he did is that he said that if you take the needle deep in, right to the other end, and not reaching the ulema, but going in. So the idea was to activate the mitochondria, and that's what he said. However, and then in his particular study, he showed that, the level percentage of total failed fertilization was much lower. However, it has not been repeated or by anybody else, or rather reported by anybody else. So it is just one kind of a study that I have come across. But of course, the most popular ones are the chemical ones. And personally, I feel that, as much we avoid the mechanical ones, it's better because it's too much skill dominated. And I would definitely, if we find more data coming, I would rather go with PLC zeta. Although calcium ionophore has been used for the last many years.
Another question is regarding any studies that support quantification of PLC zeta in an individual sperm?
No, not yet. But they should be coming up with maize because they have measured the PLC zeta. So there are studies which have measured PLC zeta and found that the levels are low, but they're still not available in that sense. So if anybody wants, I can share that reference by the end of the seminar. I can put it up and you can share it with the readers where they have actually gone. It's a very, very recent study just earlier this year.
Sure, ma'am. It will be a great.
Yeah, sure.
Is there another question? Is, ma'am, is there any risk associated with the parthenogenetic activation by artificial oocyte activation?
There's no risk because supposing there is parthenogenesis, then what will happen is that the embryo is not going to go further. So yes, I'm not really worried about that risk in that sense, because if like parthenogenesis is basically, I would say, a waste of an embryo. We wrongly believe that it has developed and we go ahead to transfer it, but it's not going to create any problems in that sense, except a failure or no implantation. And if you're going to blastocyst, it's not going to go that far. However, the concern would be that whether there would be, it is still very hypothetical, but whether it would create any problems in the newborn child. Fortunately, whatever studies have come so far and they've monitored, they don't find anything. So, and possibly if we get to know the levels of PLC zeta in sperms, and then we actually manage to inject that levels into the oocyte, then I don't anticipate, because it's something, it's a physiological limitation which we are overcoming by injection. So then, in my knowledge, it should not create any harm. However, when we are playing with human embryos, we need to be very cautious, and it's better to get data before we start applying it left, right, center. So that would be my very, careful statement.
So again, thank you so much, ma'am, with taking care of time. So I'm now passing the session to Pankaj, Dr. Pankaj Kaikade. Pankaj, screen is to you.
Thanks, Rahul. Thank you, madam. It's lovely to hear you.
Thanks, Pankaj. It's always nice.
Let me introduce to the next speaker. He is Dr. George Debris, who is an IHRA certified clinical and research embryologist. He's been practicing clinical embryology combining with genetic analysis and research in human reproduction. He currently holds the Deputy Scientific Director and Laboratory Supervisor at Westmead Fertility Center at the University of Sydney. His research interest consists of development of improved methods of assisted reproductive conception. During his studies and professional career, he has developed a range of clinical research and teaching skills. He has a number of international publications to his credits, and he conducted many workshops at international level. So over to you, sir. He's going to speak on fertilization marker of embryo selection. Over to you.
Thank you, Thank you, Dr. Pankaj Kangade, for the kind introduction. Thank you to ihera and to Dr. Ved Prakash for the invitation to join in during this 100th and ceremonial webinar. So,
thank you.
My talk today is on fertilization markers for embryo selection. So, as we all know, when we do IVF, not all of the cycles are successful, and there's only a limited number of those cycles that end up in pregnancy. So, in the last few years, and especially here in Australia, we have tried to introduce single embryo transfer rather than transferring many embryos in order to minimize multiple pregnancies and all the risks associated with those. And therefore, in order to find and identify the biomarkers that define the best embryos would give us a good insight into the embryos that can have a higher implantation potential, and in order to avoid extensive cultures. So in order to identify the fertilization markers, we just have to look through the events during fertilization, and there is a number of different events, starting from the sperm capacitation, and there is a number of molecules secreted from the oocyte that stimulate the sperm. And as we can see here in number A, then in number B, we have the acrosome reaction, where a number of hydrolytic enzymes are involved. And then we have the fusion of the sperm with the plasma membrane of the oocyte. And once again, a number of different molecules are initiated in that reaction. And then we heard this lovely talk about Dr. Rajvi Mehta about the oocyte activation and the cortical reaction that follows. And once again, we have a number of enzymes that are released by cortical granules in order to digest the sperm receptors and to block polyspermy. Thereafter, we have the sperm chromatin decondensation to form the male pronucleus. And once the oocyte nucleus completes the second meiosis and eliminates the second polar body, it also forms the female pronucleus, and we have the zygote formation. So what types of fertilization markers do we have therefore? There are three types of fertilization markers. Once we have the molecular markers of fertilization. So those comprise of all the markers that regulate those events that we have just gone through. So from the sperm capacitation to the zygote formation. However, as embryologists, those markers cannot be identified while we're growing these embryos in culture. So therefore, they're not useful into what we do. We also have the genetic markers of fertilization, which is the second category. So during fertilization, as we all know, we have the haploid sperm and the haploid oocyte that combine to form the diploid cell, which is the zygote. So that diploid status of the zygote can only be identified if we are doing pre-implantation genetic testing. But not all the patients that we have through coming for IVF will go through pre-implantation genetic testing. So therefore, this is a very useful marker to have, but is not applicable to all couples that come through for treatment. The third category is the morphological markers of fertilization. And as embryologists, we're more familiar with those because these are the ones we assess according to what we see under the microscope. So when we're talking about morphological markers of fertilization, the most obvious thing is the pronuclear formation that we see. So we know that the evaluation of morphology is the most important parameters in order to evaluate, first of all, the timing in order to also provide the indication of a chromosomal failure or degeneration. So fertilization most often is practiced at the observation at 17 hours post-insemination. And we also have to take into consideration that when we're doing conventional IVF, those zygotes will lag approximately 1 hour behind the ICSI zygotes, just because we're bypassing the natural fertilization events. And as we all know, normally fertilized eggs will have 2 even pronucleates. However, sometimes we observe either a tripronuclear formation or a monopronuclear formation. So pronuclear formation, as we can see in this image here, is the 2 pronucleates we can see in this image here. So following the sperm entry, 1 haploid chromosome set has penetrated into the cytoplasm of the oocyte. And this condensed DNA has to first be decondensed. So therefore, the paternal pronucleus expands and it's wrapped around and enclosed into a nucleic membrane that contains the DNA. So at the same time, the maternal pronucleus also forms. After the second polar body extrusion, the maternal chromosomes also get enclosed by the nucleic membrane and decondense. And the formation of the pronucleus is very important because this is necessary for the synthesis of the DNA in order to duplicate the DNA before the cleavage initiates. So when we see a monopronuclear formation, we see that following either conventional IVF or ICSI, and there's 1% chance that we see that 1 pronucleus is being observed. So when sometimes we only see 1 polar body extruded, we might assume that this origin of the 1PN might be of parthenogenetic reasons. However, sometimes we could see 1PN as an error of the fertilization process in terms of asynchrony in the PN formation or the fusion of the PN formation. So if those observations are a result of the later, then that embryo could well in fact be diploid. And even though the aneuploidy rates have been shown to be higher in 1PNs in comparison to 2PNs, the use of these monopronucleate zygotes following blastocyst culture and pre-implantation genetic screening has been suggested in terms of rescuing these zygotes that are formed. When we talk about tripronuclear formation or a 3BN, those originate again from either IVF and ICSI. And there's a higher percentage when we're using conventional IVF to get 3BNs. And this is because of the deandry. So basically the process of polyspermy not being blocked and more than 1 sperm entering the oocyte cytoplasm. So it can, of course, be caused by other reasons, such as failed cytokinesis or fertilization by a sperm that has binucleate. In regards to ICSI, approximately 1% of oocytes are 3BNs, but those are mostly digenic due to the failure of extrusion of the second polar body. And here we can see a couple of articles that show that these 1PNs and 3PNs sometimes can be used after genetic screening and in order to create viable embryos and live births. So therefore, should we transfer those embryos, especially when we're talking about the monopronuclear? So there was this interesting study in fertility and sterility a couple of years back, last year actually, that showed that even though the 1PN embryos in comparison with the 2PN embryos show a decrease in live birth rate when they are being transferred, when those are grown to the blastocyst stage, the live birth rate is very similar, doesn't have statistical differences. So even though that this study was a retrospective study, it just shows that the concept of transferring rather than discarding 1PN embryos is very important to consider. And this is particularly important for patients that might only have 1PN embryos. And in other situations where 1PNs can increase the number of available embryos for transfer. Of course, we have to take that in caution in terms of like the 1PN embryos might be less likely to form good quality embryos. Hence, if we grow them to the blastocysts, we can determine that. However, they are also more likely to be unemployed and less likely to result in live birth rate and may result in a child with abnormalities. I have to tell you that within our program, any 1PN embryo that we have biopsied and done pre-implantation genetic testing for, and none of those has came back as haploid. They were all diploid. So in terms of fertilization, when we're assessing fertilization, there's a nice definition of assessing fertilization given by James Cutt, that this assessment of fertilization should be straightforward because the fertilized oocyte should have 2 pronuclei and 2 polar bodies, simple as that. However, that when we check fertilization, usually that is a snapshot of events. And this has been illustrated by time-lapse photography, where we can see that sometimes the observation changes, and that can be seen only if we have a time-lapse camera, that the 2PN might be 1PN or a 3PN becomes 2PN, depending on the time of the observation. So in a clinical study where 22,000 fertilized oocytes were assessed right at the correct timing, as it is suggested by Escher, 8% of those zygotes were already in syngamy, therefore suggesting that there might be a different time to assess fertilization. So therefore, are we excluding embryos if we're not using time-lapse imaging? So another aspect for the definition of the fertilization is that the requirement of the 2 polar bodies. Sometimes polar bodies can be fragmented, and again, if we're using a snapshot marker of seeing that that event, it could be that those polar bodies are disintegrated, and therefore we might mistakenly assume that they are parthenogenetic. In terms of morphology, pronuclear scoring has become a matter of assessment, and this has been suggested by Lynette Scott with the Z scoring. And according to this scoring, pronuclei should be of similar size. They should be closely opposed and centrally located in the fertilized oocyte. So pronuclear scoring takes into account the symmetry and the alignment of the pronuclei, and involves the assessment of the number and the relative position of the nucleolar precursor bodies, which are established in the pronuclei. So ideally, there should be 5 to 7 nucleoli in each pronucleus with similar distributions in each, and any inequality is considered to be abnormal. And therefore, according to Lynette Scott, the zygote should be rolled in order to have an optimal plane and observe carefully and score the zygotes. So here is the Z scoring that has been suggested. Here is a schematic representation. And there is 4 scores, starting with Z1 being the good score, where we have equally and aligned pronuclei with maximum of 6 nucleoli. We have the Z2 score, where we have equally and non-aligned pronuclei and max of 6 nucleoli. We have the Z3 score, which has subvariations between 1 to 4. Whereas we can have either large nucleoli scattered, aligned and non-aligned, unequal numbers, or many small scattered nucleoli. And then we have, when the pronuclei are separated, the Z4 score, and when they are of different sizes, and when they are not centrally located and are at the periphery. So is this useful? Is pronucleate scoring useful? So this has been investigated by many groups, and a lot of publications have shown a benefit in pronucleate scoring and the distribution of the nucleoli. However, there are other reports that have shown no benefit in pronuclear scoring. So Escher and the Istanbul consensus has determined that pronuclear scoring is of value as it can provide additional information about the zygotes, and that it should be performed during the fertilization check. And Escher has came up with 3 categories for the scoring, and those are the score 1, which is the symmetrical, which are the equivalent to the Scott Z1 and Z2 score. The non-symmetrical, whether they have other arrangements, including peripherally sided pronuclei, and the abnormal, where we have pronuclei that have 0, or the bullseye, as is being called, where there's only 1 nucleoli. So other appearances of the pronuclei, as we can see in these images over here, we can see that there is a differences in size, where we can have at the top image here we have small pronuclei, and we have larger pronuclei in the bottom image. So this has been shown that it is depending on the time that we are observing, as the size of the pronuclei increases by 50% from the time of formation to 17 hours post-ICSI. So it all has to do with the time, again, at which we are having a look. And the presence of pronuclei with a diameter that is less than normal can be an indicator of delayed fertilization, and that could be possibly due to oocyte immaturity or defects in the gametes. However, even if we have smaller pronuclei, implantation can be seen. So another factor in terms of the pronuclear morphology is the alignment, as we can see in these images here, where the extrusion of the second polar body establishes the polar axis, and the correct alignment of the PNs on this axis is necessary for the formation of the polar axis at syngamy, and the division that follows. At a position, the chromatin of both PNs begins to polarize and rotate in order to face each other, as we can see in the image, with the longitudinal axis of the PN being parallel to the plane of the polar bodies. And then further rotation brings the PNs aligned onto the polar axis, as we can see in the second image. And the position of the second polar body then defines the plane of the first cleavage division. Is the angle of any importance of the polar bodies? Here we can see an image where the polar bodies are rotated in more than 30 degrees, and they have a large degree of separation between them. And this is assumed to result in suboptimal development, according to this paper that was studied. And the large angles between the polar bodies have also been suggested to be predictors of poor embryo development. And this effect is believed to origin in the suboptimal orientation of the PNs, affecting the cytoplasm, and thereafter leading to uneven cleavage and fragmentation. How about when we observe PNs that are separated? This is another common feature we see during fertilization. So even so, the apposition between the PNs. So that is controlled by the sperm centromere. So this is very necessary for the distribution of organelles in the cytoplasm. So therefore, failed progression to apposition and syngamy will depend on the sperm centrosome activity. And observations of zygotes with separated PNs have shown delayed development and embryo arrest. And sometimes it has been associated with immaturity of sperm if the source of those have been from epididymis or testicular extraction. So is the PN position relevant? As we can see in these images here, we have centrally located PNs and peripherally located PNs. And the position of the PNs has a relevant effect on the first cleavage plane. And when the PNs are positioned centrally, then the division is usually happens in a regular way, giving rise to normally developing embryos. However, when the PNs are positioned peripherally, the cleavage that follows is according to the pronuclear axis, and sometimes it can result in abnormal morphology. However, once again, implantation and live births can be achieved even if the PNs are located in the periphery. So how about overall morphology of the zygotes and in terms of the cytoplasm? Usually that has to is mostly defined at the injection if we're using ICSI as well. And we do hope to get the homogeneous cytoplasm in zygotes. However, sometimes heterogeneous cytoplasm cannot always be predictive of the developmental competence. So some studies have reported that severe cytoplasmic anomalies can affect the developmental and implantation potential of the resulting embryo. However, there is no clear evidence to support it. And therefore, recording of cytoplasmic morphology can show some relevant links to developmental or implantation potential. So, for example, this oocyte here with the cytoplasmic clustering of organelles, that could be a sign of immaturity in terms of cytoplasmic maturation of the oocyte. So is there really value in scoring at the fertilization? So there is a lot of debate regarding the value of pronuclear scoring. Some studies have shown a prognostic effect with the scoring at the PN stage. And PN scoring has also been correlated with aneuploidy. However, a number of other studies have not found a positive predictive values. So where does it apply? If there is legislative issues, for example, in some countries where embryos are required to be selected at the zygote stage, this can be of a very significant parameter to assess. But it is important to understand that the assessment of these early parameters can only provide an indication of the gamete quality and the development over the first couple of days, because embryonic genome activation only happens thereafter, and that can only be looked at between days 3 and 5, and that reflects the gene expression, the differentiation, and all the developmental controls. So ultimately, even if we score early, we don't have the full picture. So in summary, morphological markers of fertilization can elucidate the developmental timing and provide an indication of chromosomal failure or degeneration. Unless we use time-lapse and unless we use genetic analysis, the diploidy status of an embryo cannot be validated to the full extent. And also assessing morphology at the zygote stage can provide some insights, but it's not a prerequisite for further developmental capacity and predictive of cycle outcomes. Thank you very much for listening.
Thank you, sir. It was a wonderful talk. There are 2 questions. I'll go one by one. So there is one question. What are your recommendations for performing rescue ICSI as there is no fertilization on day 1?
We don't perform rescue ICSI just for the simple reason that by the time that we assess fertilization, these oocytes will most likely be post-mature, and therefore it can sometimes bypass the fertilization by having PN formation. But really practically in terms of chances for live birth, it might be most practical for these couples to undergo another fresh cycle and get the eggs collected again and reinitiate the process from the beginning.
Another question is there was one slide in the pronuclear morphology. So the early syngamy, what does it mean with embryo quality and outcome?
The early syngamy?
Yes, there was a slide in the pronuclear morphology. The early syngamy, what does it mean with embryo quality and outcome?
Usually the embryos that are found to have early syngamy are the ones that have been associated with better developmental potential. So once the syngamy is happening earlier, usually these embryos will form blastocysts earlier as well. So if we are able to determine those embryos that are formed during syngamy and we don't discard them, we could indeed have embryos that give the highest among the highest implantation results. So that is where the importance is in terms of identifying which are the real haploid embryos and which are the ones that we have missed by the fertilization check. And unless we have ways of visualizing that, and that would be the time-lapse imaging, and further by genetic analysis at further stages of development at the blastocyst stage, we cannot be sure of that outcome. But one factor is because we don't expect haploid embryos to grow very well to the blastocyst stage. Is if we're in doubt, to at least that's what we do, is to grow these embryos and see how they grow over the next stage of development to the blastocyst.
Thank you, sir. Thank you. It was a wonderful talk. There are a few more questions in the discussion going on. I'm just confused whether it is a discussion or they are asking some questions. Anyway, we'll get back. I pointed some questions. It was a wonderful talk. Thank you so much.
Thank you.
Thank you, sir. So we'll move forward for the next session.
Thank you, Dr. George, for coming and joining us. I know you have to leave now. There is late night over there. So thank you so much again, and see you on 3rd October again.
Thank you, Dr. Ved Prakash. I appreciate the invite, and I have to say good night due to the time differences here in Australia. Enjoy the rest of the session.
Thank you. Thank you. Thank you so much.
Bye-bye.
Bye-bye. Bye-bye. Rahul is there? Pankaj, you just start with introduction, na?
Okay, sure.
Okay.
Hello.
We'll go with the next session. So it's a panel discussion. So we will be discussing in this panel discussion about the insights of fertilization failure, the case scenarios. So I will welcome the two first moderators. First one is no need of any introduction. He's our boss, my previous boss, Swami sir. So currently he's the president of Academy of Clinical Embryology India. Also he's a scientific director at Sanskrit Center for Reproductive Medicine, Bangalore. Then the second.
I want to add one more thing. He is very popular on social media. All the young embryologists. He's actually like a group for all of young embryologists, and he is very good friend of mine. And he is the, I think, best friend in all the our community.
The embryologist with the golden heart. The embryologist with the golden
you are
heart.
right. Yeah.
Welcome, sir. Then coming to the next moderator, she is Dr. Saroj Agarwal. She is the Chief Embryologist at CARE IVF, Kolkata. She is associated with this center since 2007. He has successfully set up the first PGS and PGT facility in West Bengal, started an oocyte freezing program, first of its kind in Eastern India. She is also executive member of ACE, then ISAR and IFS. She is an MSc gold medalist. Her special interest lies in total quality management of ART laboratory, PGS, PGD, the oocyte freezing, and DNA fragmentation. So over to you, over to both of you.
Thank you, Pankaj. Thank you for that introduction. Thank you.
Yes, 1 minute. I will share the screen. Thank you, Pankaj. Thank you, ihera. Thank you, Ved, for the nice introduction. And it is pleasure to be here along with Dr. Saraj Agarwal. Actually, today the panel discussion is that insight on fertilization failure. We have the esteemed panelists here. I'm happy to introduce our panelists. We have 4 people. Shrikant Ethanale from Pune, Parag Nandi from Kolkata, Geeta Goswami from New Delhi, and Avinash Tiwari from again New Delhi. Let me take the pleasure of introducing my good friend Shrikant Ethanale, who is having more than 25 years of experience in the field of embryology. Almost every one of us know him very well. A good friend of mine, a great senior embryologist. Next, of course, our young and dynamic Parag Nandi, who is scientific director and clinical embryologist from Cradle Fertility Center, Kolkata. And he is a former research fellow, University of Kolkata, and currently he is the scientific director, Cradle Fertility. And he is the founder, life member of ACE. Of course, he is the proud creator of ACE official logo, what we have in today. And he is a life member in various societies and in the specialist interest group. And he has been trained from Crest, Bangalore, and published lots of research papers. And he's a very active man, a very good photographer, very good friend of mine.
Thank you so much.
Thank you. And next, Saroj.
Next is Dr. Geeta Goswami, MSc PhD. She is currently the scientific director at Ridge IVF Private Limited, the R&D head, Lab India Life Sciences Private Limited, senior scientist at Genetic Department, Delhi University. So her specialization includes genetics, molecular biology, and embryology. She's a gold medalist in genetics from Delhi University. She's a member of ACE, ESHRE, and she got her training in embryo biopsy from the University College of London and Memorial Hospital, Turkey. She's been trained in PGS using FISH, IRACGH, and NGS, and she's published papers in various national and international journals. So 1 second, so I can't seem to be, 1 second.
Have you got it, or I can go?
So you can, so I don't have that part.
Yeah, next one we have Dr. Avinash Chandra Tiwari, who is MSc MPhil PhD, and he is the former chief embryologist and scientist too from Art Department of All Indian Institute of Medical Sciences. And he's clinical expertise since 1999, member of Indian Fertility Society, and he was academic executive committee member of ACE. At present, he is working as a senior clinical embryologist in various labs. Happy to welcome you all, dear friends, to this interactive panel session. So let us start. Good. So improvement is the integral part. Don't excuse with the word busy. So don't try to change the square wheel with round wheel. When someone is asking you, change the wheel, don't say that I am very busy, I can't do that. So you will be in trouble. So science is a integral part. It's a change is happening. We have to update ourselves. These kind of programs will give some inputs what's happening outside. So be a sensible pilot. We are the pilot in the embryology lab. There is a figure there. It says the pilot announces, ladies and gentlemen, this is your captain speaking. There is a minor malfunction in the pressurization system, but no problem. An oxygen mask will come out of the unit above your seat automatically, but there is no roof only. So as an embryologist, as a pilot of the team, you should know what's happening in your lab. So we know that sperm and egg, sperm and oocytes are separately very complicated. When they mix together, they are surprisingly complicated. And the main biological raw material for fertilization is the matured oocyte and the matured spermatozoa. Apart from this, as an embryologist, as a clinical embryologist, you are challenge with work with more than 200 variables in the lab. That's why it's called assisted reproductive technology. We rather use more technology rather than the biology, except your sperm and oocyte, more of technology is involved. So that's why that can be controlled, where your raw material can't be controlled, it is already prefixed. So understanding the biology of the gamete and the sperm is very, very important for any clinical embryologist, because through supply of maternal derived proteins and regulation of molecular and biological signaling pathways, the oocyte and the sperms are largely responsible for the fertilization. As you see, the gametes are prefabricated for action. You can't change it. Gamete production includes unique patterns of gene expression. It's more of molecular events. I always tell that it's not that you are handling one sperm and one oocyte. At the time, you are handling 30,000 plus 30,000, 60,000 genes. Gametes have complex structure and regulation. Every gamete is genetically distinct human individual. So this is just an introduction. We will start now. So I will ask all my panelists, what is your preferred mode of fertilization? Like how you prefer to fertilize your oocyte in the lab? You can go one by one. Maybe I'll start with Srikanth. Srikanth is there? Srikanth? He's not there. Okay, Parag, you can start off.
Okay. My preferred fertilization method, it depends on, again, the patient category which is being presented to me.
Yes, exactly.
And exactly the gamete quality and all those things actually gives me the, ask me to do that particular way. Like the conventional IVF I do if there is no such, specific, sperm problem, male factor problem, then I go for a normal IVF. But again, if the tubal factor or maybe something like that, like the specific particular one tube is blocked, or both the tubes are blocked, then the conventional IVF is being chosen. So I go for IVF. But
yes,
if there is a severe male factor infertility is there, or something like previous many failure history is there, or maybe the IUI has been done many times but it's not been fertilized, or not been succeeded, unexplained infertility, in those cases sometimes I choose for ICSI or maybe IMSI.
Yeah. What about other panelists, Geeta and Dr. Abhinesh?
This will depend on the present criteria. What is the semen quality and semen count, and depend on the oocyte quality also. Then we can decide which type of mode we can use for this.
Yes, Geeta is there. Dr.
Yes,
Geeta,
yes, I'm there.
Yeah.
I would look at the male factor, as Parag said. First of all, if it is a normospermic patient or a mildly oligospermic, then I would always go for a split IVF ICSI cycle, because I don't want to have a failed cycle for the patient if I don't have complete fertilization in complete IVF cycle. So we know that our patients are very conscious about the cost involved in IVF, and they don't want to waste their cycle. So in cases of normal zoospermia and mild oligospermia, I will always opt for a split IVF ICSI cycle.
Anybody does all ICSI? All cycle, all ICSI? No. It is all.
I think Srikanth is there. Srikanth is there.
Sorry, hello everyone. There was some technical glitch. Yeah, I could not unmute myself. Sorry, there was some technical problem. Yeah, no as Swami, you were asking 100% ICSI. Yes, at few centers, only because the doctor insists, we do all ICSIs. But
doctor's embryologist.
Yeah.
Doctor's darling.
Yeah, doctors wish, I can say. Being a freelancer, we have to keep doctor also his own choice, like what he wants the way to this thing also.
Yeah, because
ICSI is not bad, so that is better only. So there's no problem.
Yes.
Basically, I would prefer looking at the semen parameters, early cases done, and morphology and nuclear decondensation test, if anything is there. So that would be more important. The parameter will be more important.
Yes. So the given the option that you will go case specific and decide
Yeah,
to
yeah,
do.
yeah,
Very
yeah,
simple. It's very simple.
yeah,
So that's what I want to clear. It's very simple. Excellent. Thank you. So what is your experience? In short, have you faced your TFF, that is total fertilization failure or low fertilization failure? Don't explain. Have you faced? Of course, you must have.
many times.
Yes. Okay. Okay.
Yes, we have faced.
So it can be predictable.
No.
No.
In
Everyone.
some cases, I do agree. Like in some cases, the previous history of that patient, if they have previous fertilization failure history,
yeah, okay,
then sometime there is a chance that we can get this.
Yes, fine. Okay,
I would like to add that if you get when you screen the eggs, you come to know whether the eggs are actually really mature or not. Small eggs with tight cumulus complex. And if the trigger is, stimulation is given for only 8 days or something, sometimes the size-wise, the follicles, if the aspiration is done before maturity, then that time we expect, I think there would be less fertilization. That is a pre-prediction. Goes like,
yeah. The TFF is a nightmare for any embryologist, because if you take in IVF cases, it is about 5 to 10% and more width of sperm abnormalities. If you take the ICSI, it is 1 to 3%. Again, maybe because of the oocyte quality, and it is 30% recurring. You know, it suggests that to some extent it is not random and it could be predicted. Understanding the etiology of the fertilization failure in the previous cycles are the critical importance to assist the patient counseling in the upcoming cycles. So, everyone must have experienced in our lifetime the TFF and the low fertilization rate. So there are various factors. We know that, starting from sperm factor, oocyte factors, of course the technical factors. So if you see the contribution of sperm, even the sperm motility progression and the sperm origin and sperm maturity, all these parameters contribute for the fertilization failure from the part of sperm. I don't want to explain because it's a panel discussion. Just to give a overline to the audience that how we are proceeding, the factors involved. There are lots of papers available whether the novel technique can overcome this. And of course, from the oocyte side, we have the maternal age, oocyte maturity, oocyte activation. Of course, that's what our prime concern today. The whole TFF and the low fertilization, the contribution of the oocyte is almost very high compared to the sperms, and the low ovarian response. Of course, when you have the raw material less, there is no option. And of course, the technical error, that's what we need the expertise, the experience comes. How to do the ICSI, because the first calcium ion unchelation takes place in the injection itself. So once you miss that bus, the fertilization is not going to take place. So it's not only the immobilizing the sperm, then how you are putting the sperm inside also important. It's not merely technical, it is a science. And one should understand this. This will take some time for a newcomer to understand and do the make the technique perfect. And we know that there are lots of molecular role of calcium ions in the fertilization. That was explained very well by our Dr. Rajvi. So this is the basic. In these basics, we may discuss a few kind of case scenarios. Now over to my co-moderator to Kolkata.
Thank you, sir.
Raj, thank you.
One second. Yeah, so we start with the case scenarios. We have made very interesting small case scenarios so we can discuss it in detail. This is a 35-year-old woman with a diagnosis of tubal factor. So one second.
Yeah, no problem.
I changed. So can I share my screen if there's some problem here?
Yeah, you close it. I will come out of this.
One second.
You can share yours.
One second. So where did this go? So one second. Yeah, sorry for that disturbance. A 35-year-old woman with a diagnosis of tubal factor, a borderline AMH value, and mild endometriosis sought IVF treatment at a center and trying to conceive for 4.5 years. Now, she had previous 3 cycles, all failed. She had 2 FSH intrauterine insemination, which failed, and 1 natural IUI cycle, all failed without any implantation. So now coming to the first cycle, the first cycle was an IVF cycle. There were total 19 oocytes were retrieved. So there were a good number of oocytes retrieved, and the husband's sperm had normal count and progressive motility. None of the 19 oocytes, when done IVF, had pronuclei, all in the next 18 hours. 12 oocytes had single polar body, clearly stating that there was no IVF, and 4 had 2 polar bodies. Now, all oocytes look normal, as Shrikant sir said, when you do the screening, all look normal, gross morphology was okay, there was good sperm attachment. Now, it's a failure, fertilization failure. Now, let's go, how would you salvage this cycle? And then we go what could have been done. But if you don't have any fertilization, what would you do to save the oocytes or right now? Dr. Shrikant, can you take that question?
See, there could be, if 2 polar body is seen, so that means there is some fertilization in that oocytes. Okay, 4
Yes.
had that 2 polar bodies, or maybe split polar body. We are not sure whether it's actually fertilization or it's a split polar body. So, and the number of oocytes, 19 are there. So, if while screening itself, the cumulus complex and everything was normal, then I would say there is some problem with the sperm itself. Because there could be sperm morphology problem, the acrosome should be a problem, or nuclear maturation should be a problem, or ZP binding site, that is also. And apart from that, major thing is the lab and this thing condition. You have to be cross-checked with other cases if you are done simultaneously, if you got fertilization in the other cases, same time, so there is no problem with the lab. That particular thing what I, except for infection, you should rule out. That also sometimes it is missed.
So you're saying in the next cycle, we would go with a better sperm morphology, see and do ICSI, right? That's what you're trying to suggest.
Yeah.
But in this cycle, what would you do?
Rescue ICSI. Rescue ICSI is a chance where we can try immediately at the like 17, 18 hours. Usually ICSI, we see 17 hours post ICSI, Pronuclear 18 hours. And in IVF, we see 18 to 20 hours. So if no polar body is seen, even after 20 hours, 2 polar bodies and no 2 PN, definitely we can choose them for rescue ICSI.
Dr. Avnish, you have any other version?
Same problem I have faced so many cases. On next day, I was seeing there is no pronuclei or no fertilization. Then we referred for the rescue ICSI. I have done so many cases and delivered the baby in such cases.
So you had this in rescue ICSI?
Yeah, ma'am. This is the lasting result in rescue ICSI after.
And at what hour were you doing rescue ICSI, sir?
Sorry?
At what time were you doing rescue ICSI? Like 17 hours, 18 hours?
20, after 20 hours.
After 20 hours, okay. Parag, any experience in rescue ICSI?
Yeah, I did twice or thrice, but out of that, maybe once I got fertilization. But my suggestion would be that in the next case that we have to do, yes, obviously ICSI, but better as Dr. Geeta was saying also, like I do also like the half IVF, half ICSI, if there is any kind of, confusion is there. So, so that is a better way of, seeing the matter. In this.
I can't see Dr. Geeta on the panel, I mean on this thing, gallery here. Are you there?
Yes. Am I not audible?
Yes, you're audible.
Yes.
Please, your views on it. Views on it.
I'm not a proponent for rescue ICSI because I have done 3-4 cases rescue ICSI and I always end up with multiple PNs. What I feel is that maybe there is late appearance of the fertilization, the sperm has entered in conventional IVF, but maybe because of the oocyte factor or sperm factor, we're not able to see the PNs. And when we do a rescue ICSI, that's triggered, it gets activated, and then we see multiple PNs. So I'm not successfully got results in rescue ICSI.
So something should come and rescue you.
As such, because I've ended up seeing multiple things after
as particularly as in this particular cycle, how will you salvage it? ICSI is the only this thing, na?
Only option.
Yes. So rescue ICSI is the only option, but there are many papers which say that if you check the fertilization at post 6 hours, when you see that the second polar body is not excluded, if you do rescue ICSI at that time, you get almost 70% chances of fertilization, rather to a 20-year-old, 20-hour-old oocyte, which is the oocyte is aged, and the result of rescue ICSI is not that good.
Definitely, yes. We do get good embryos. I have got good embryos. I have noted that, but I have not got pregnancy. Very honestly, I'll tell you.
But saying that, is it practically feasible for anyone who is running an IVF unit when you fertilize, inseminate the eggs at around maybe 5 p.m. or 4 p.m. to check after 6 hours? It's not possible. So that's the reason why I think the result of rescue is not very good, or it's not very practical for us to follow.
No, it has to be only after 16 hours. You can't say, because if it is a IVF, there could be a chance where M1 oocyte gets matured in vitro, it becomes a M2 and then get fertilized, allows fertilization. We have seen many a times, like it might happen. Okay, so you can't judge like if only after 6 hours you denude them and check. Dr. Suresh's paper is that. If I recollect, Dr. Suresh.
But there are various papers on this which suggest a 6-hourly after insemination 6-hour check and do rescue ICSI at that time, which gives perfectly good results. Yes.
Same reference was there. It is not practically possible.
Multiple pronuclears. That also.
So instead, if that is to be done, instead I will do ICSI. That is the best way to do.
Okay, now let's go to the second thing. In the second cycle, because we know the first cycle was IVF and it wasn't, successful. The second cycle was a standard ICSI cycle. We got 21 oocytes, and since all 20 oocytes were M2, and sperm from the husband was used to do ICSI. None of the 20 injected oocytes again exhibited pronuclei 17 hours later. So although sir, you're saying something?
No problem. Carry on.
Okay. Although each of the 17 oocytes had 2 polar bodies, gross morphology of these oocytes appeared normal. Now here, what could have gone wrong? And let's say you know what's wrong, and how would you plan the third cycle for this patient? Parag, you can take this question.
Well, let me go through one. Yeah.
Standard ICSI. Yeah.
So standard ICSI has been done, right?
Yes.
So in that case, maybe artificial, oocyte activation can be an approach that can be done, and yes, that would be I think the better way. Like
only option.
Yeah. So artificial ICSI, sometimes it happens like the egg could not be activated. That is.
But it says 17 oocytes had 2 polar bodies. That means there was oocyte activation and fertilization did occur, right? But polar body, and there was only polar bodies, 2 polar bodies, but there was no pronuclei. So you think it's an oocyte activation seen here?
But none of those 20 injected oocytes exhibited pronuclear 17 hours later, and although each of the 17 oocytes had 2 polar bodies, but gross morphology of these oocytes appeared normal.
I'm just asking you, maybe I'm just confusing you. I'm just asking you, even if they are polar bodies, do you think it is an oocyte activation problem?
17 had a 2 polar body. That is, the oocyte is completely mature. This the main problem depends on the sperm side.
Geeta ma'am?
Yeah, I just wanted to know how was the sperm of the husband? Was it?
No, good sperm.
The good sperm.
No problem with the sperm.
Yes, no problem with the sperm. Then it appears that there is a activation deficiency there. oocyte activation deficiency.
Yes.
It may be cytogenetically abnormal of the oocyte quality.
Pardon, I didn't hear you.
It may be in a cytogenetically abnormal.
Yes. So though we can say that the oocyte activation didn't happen here, we would go with an oocyte activation next cycle. But seeing all the criteria here, we feel it's more a cytogenic effect more than anything else. But if we have to plan a next cycle, obviously I think we'll go for an artificial oocyte activation in the next cycle and see how it goes by. Because even if it is cytogenic, you can't exactly do anything about it. We can just try oocyte activation and see whether the third cycle goes.
Can I just,
yes,
as Rajvi was mentioning, right, like sometimes after syngamy, we miss that thing, like in a half hour or 1 hour. So we can't predict that exactly there is a fertilization failure if you don't see the pronuclear. Some might have gone actually past the syngamy. Okay, so you have to wait for another 3-4 hours. If two polar bodies are seen, everything is normal, wait for another 3-4 hours and then take a call. That is what I this thing
okay, sir. Okay. So the only thing we can do is in the next cycle, we can counsel the patients that we can do an ICSI with an artificial oocyte activation, because that is the only way how we can proceed forward. Even if it is a cytogenic defect of the oocytes, I don't think we can actually do anything rather than improving the stimulation cycles there to try and improve the oocytes. I think that's the only thing we can do here, right?
Yes, I agree with you.
Yeah. So I'm going to the next scenario. A 26-year-old woman was seeking treatment for a 2-year primary infertility. Her husband, 29 years old, no history of excess alcohol consumption, exposure to toxins, ongoing medical treatment, no ongoing medical treatment. Semen analysis showed severe oats with high sperm DNA fragmentation. On the day of OPU, 14 oocytes retrieved, 10 M2, 1 M1 and 3 GV, all were injected. On the day of fertilization, only 2 fertilized. This is not a case of total fertilization failure. This is a case of low fertilization failure. Now here, what could be the cause and how would you proceed with this patient in the next cycle? Dr. Geeta, you can take this question.
Yes, I would love to. Because we have done work on lots of OAT, severe OAT patients. And I have seen that with these kind of patients, if we do INSEE and we select the sperms, we get good fertilization and good quality embryos and good implantation rate as well. And another thing I have read in the recent papers that by doing INSEE and by doing selection in INSEE, they have measured the PLC zeta levels. Okay, so if we are selecting the INSEE sperms and they've seen that the PLC zeta levels are very good in these kind of sperms. So when we are doing INSEE and selecting the sperm, that means we are really selecting a good physiologically good sperm, and then that is why we are getting good fertilization and good embryo quality in these cases.
So according to you, what would be the cause of low fertilization here?
It's the sperm quality which is affecting, because the sperm might be deficient in PLC zeta also.
A high sperm DNA fragmentation is also considered.
Dr. Abnesh, you can.
Yes.
Doctor, you can kind of like, do you have any experience with IMSI? Have you done IMSI?
You're asking me?
Dr. Abnesh.
Okay.
Very little experience about IMSI. Depend on the morphologically selected sperm found in such cases. But in such cases, the high sperm DNA fragmentation is found. So the fertilization or the chances of fertilization is very low in such cases.
So what would you do if you don't have an exposure to see? How would you go ahead with this patient?
Mostly, I am suggest for donor sperm in such cases.
Best.
Okay.
Finish that.
Shrikant sir?
Severe oligosteroid, like you can treat the male patient by that time. You can plan that cycle that way. And if it is DNA fragmentation, sometimes, some cases they suggest that testicular sperms are better than the ejaculated sperms in that case. So you can use that. And if you are going to ask me about that IMSI, I have never done that.
Okay.
Parag,
do you think that any of these advanced sperm selection will help the patient here? Because when we are saying it's high DFI, do you think microfluidics, MAX, IMSI, ma'am has said, that can be done, but IMSI, most of the people do not have the apparatus to do IMSI. So would you go for a PIXI, MAX or microfluidics in this case?
See, in this case, one thing is for sure, there is a severe male factor problem, like the sperm
Yes.
problem is there. So in that case, we have to be specific about the sperm selection. So there is a IMSI is one tool by which you can select the sperm. Yes, I have seen in my PhD days, like the one acridine orange I used to do a lot. So at that time, I used to see like the the morphologically abnormal sperm maximum. That morphological abnormal sperm was showing like the fragmentation. So
Yes.
so in that way, I thought like, okay, fine. So if the fragmentation means like the morphologically defect, so if the morphologically normal sperm, if I can select, that can give us a good better outcome. So yes, IMSI or any Pixie or Max or something like the microfluidics are all those are upcoming, but yet to be little confusion is there, like whether they can, and the yield is lesser in case of ICSI or IMSI, whatever you are utilizing. If you are doing IMSI, that there is a one way. If you are doing ICSI, you don't have IMSI, then if you choose that particular sperm by Max or Pixie, then it would be easier for you to be sure like that particular sperm may be having better fragment DNA integration.
What do the other panelists feel here? Like, would anyone go for Max or microfluidics, or like Dr. Abni says, straight away try a donor sperm there?
Both simultaneously, we can try to treat the patient. We can give one month, 2 months.
Give some time, yes.
So that time you
So in such cases,
high antioxidant
cycle, this also can be it's a handy. You can definitely use. There is no harm using this. So, but
I'm very surprised that the other panelists haven't spoken about testicular sperm, because I think in this patient you should give a try about, with the testicular sperm, because the DFI would, Shrikant sir said, but none of the other panelists have kind of discussed this. But testicular sperm can be one of the solution here. We can try. See, yes. Sir, you want to say anything?
No.
So the use of DNA fragmentation testing and testicular sperm for intracytoplasmic sperm injection, there have been various studies which show that if they have very high sperm DNA fragmentation, testicular sperms can be used, and they have given good results in many cases. Dr. Gira, you want to comment anything here? Since you are very, deal with sperm DNA fragmentation, so I just wanted to ask you.
Hello. Yeah, you asking me?
Yes. Could you hear me?
You see, I have seen many of the patients don't want to go for this essay experience. It's a painful experience for them. So they always tell us, if you can do away with this sample only and things like that. So it's my experience in IMSI that we have been able to give a good take-home baby rate in these kind of patients, severe OAT cases also. So there is lots of time involved in doing IMSI though, but it's worth doing for these patients, because we also know that everyone wants to have their own biological child. So giving an option of a donor sperm right away is not acceptable for these patients.
No, right away no one will accept. Maybe you have to see that, what is if you say the scientific proof, maybe people may accept that.
Yes,
No one can push. We have to give the option, the patient should select. We are not in the place to order or something. We will give the option, this is what, then they can select. So we are also dealing with their biological product. See, we can't do anything if it is not fit to procreate. That we have to prove scientifically.
What we can also do is counsel the patient, say half the oocytes we're going to do with testicular sperm and half let us do with donor sperm. And if that fertilizes, we will transfer that only. If not, we will sort to donor, because no point going for different cycle. Patients don't want to go for repeated IVF cycles also. So that could be again one way of going it.
Yes, and another thing like that, next time the patient should be given some more time, like 2-3 months. 67 days is a spermatogenesis process. So giving some antioxidant and micronutrients and all these things, I have seen very good effect on sperm morphology as well as the fragmentation and all these things. So,
okay, let's come to the next question. Patient 32-year-old and partner 37 years, married life for 5 years, have undergone control ovarian hyperstimulation plus ICSI. On the day of OPU, 8 oocytes were retrieved. On denudation, 5 were M2 and 3 were M1. Now, this is a history of, there is a history of male factor.
Such cases, the morphology selected sperm using for ICSI.
They said the morphology is abnormal. And light microscopy showed 100% spermatozoa were round-headed.
Round-headed.
That's the male factor, yeah.
Globulus.
Yes, globulus.
It's very difficult to say anything about such cases.
Dr. Shrikant, you can take the question then.
Yeah, earlier, as Dr. Rajvi said, like PLC zeta and other factors, oocyte activation, in that technically, that micro level, we have to think in that. And globospermia, definitely, it is not successful. Very few cases have been reported with the pregnancy. Maybe recently some Japanese, if I'm not wrong. So
if there's a partial and maybe complete globospermia, so that makes a difference there.
So activation part, like PLC zeta, what she was saying, oocyte activation would be the problem there. We can try that thing.
Side is normal. Main problem is the abnormal sperm here.
DNA also should be there.
Parag, can you go ahead?
Yeah, here it is saying like 100% of spermatozoa were round-headed, means that 100% globulospermia was there. In that case, there is no question of doing, if you do even IMSI also, if you see 7000 X magnification, then also you are going to push that without acrosome, no? So oocyte activation or PLC zeta, that is the only way. But I have done this, but unfortunately, only one was active, the fertilized and did transfer, but no pregnancy from that. So that was not even very partial globulospermia was there. Like I got a little small acrosome was there, so that I injected, or that particular one fertilized, but it did not turn into pregnancy. So but PLC zeta that I was going through, that the Rajvi, Dr. Rajvi said, that is another good development which has happened. So I would really like to see rather than this calcium one, because as Dr. Rajvi was saying, like after ICSI, you have to put in this calcium ionophore. I did the same, but not all the time you will be getting fertilized.
Dr. Geeta, your views, please.
Yeah, I have done one case, and that was a severe OAT along with globospermia, 100% globospermia. There I used a simple ICSI with oocyte activation, and we have got a live baby there. So I think in globospermia, without wasting a cycle, we should go ahead with the oocyte activation if it is a 100% complete globospermia.
That's what we were trying to prove here, that total fertilization failure or low fertilization is predictable. Only if you kind of take the indications there from the patient history. When it's already mentioned it's abnormal and 100% of the spermatozoa are round-headed, your treatment plan should include AOA without any delay, because you know it's globospermia, acrosome is absent, so oocyte activation is going to be a problem. So you should straight away go with an oocyte activation cycle and not delay it, right?
Yes.
You agree with me?
And I agree with you, and with explanation to the patient, that telling that it's an experimental procedure and we are going ahead with that.
Yes. So that's what was discussed here, globospermia and total fertilization failure. Many cases where they haven't used oocyte activation, they have found total fertilization failure. There are only very few cases where there's partial globospermia. They have found maybe 3 to 5% fertilization, but otherwise it's generally the fertilization is quite poor. And that is what Dr. Raji was saying. Since globospermia, we have to understand the role of PLC zeta here in egg activation. So maybe all of us need to go ahead and read about PLC zeta and the activation process and how to go about it. So these are all studies here. We can maybe just let you know what the studies are, which show that calcium ionophore is doing a fantastic job in active oocyte activation. And I think many of us are using that, right? Instead of using electrical or mechanical, we all are using the calcium ionophore for activation. Is everyone using here?
Yes.
Dr. Shrikant? No? Okay.
No, I am using, and even I am using in poor responders also in that cases.
Swami sir, your comments.
Hello.
Are you
here
there,
only.
sir? Yeah.
Yeah. I couldn't get you. What?
I said your comments on this. What would you want to say something here?
There is
no problem.
simultaneous panel discussion going on the chat section. You also have a look over there.
I'm
So
answering
many
there.
things
Yeah.
are being discussed there.
I can't see the file. I can't see the
No,
chat
I
now.
try to answer now and then.
No,
Yeah.
they are really
Okay.
good inputs and good discussion is also going on there. It's
That's
really
very nice.
Yeah.
That means we are doing a very interesting panel if the chat is full of discussion.
That's interesting. That means the topic is interesting, and the participants and even everybody is being involved in
Okay,
that.
we come to our last case scenario because we have only that much of time. A patient, 41 years old, previous IVF cycle done. They had delayed fertilization from the standard IVF. Now 2 p.m. stage seen 2 days after egg collection. Okay, they opted for ICSI in the next cycle, recovered 2 eggs and injected both. One developed 2 p.m. 3 days later and one cleaved to a 2-cell embryo. Did anyone have these kind of abnormal fertilization, delayed fertilization? Your experience, I'm not even asking what to do, what not to do. What is your experience on delayed fertilization? Like, do you wait till the next day to see, if something has happened, or how do you go about it? Dr. Geeta, maybe you can take it first.
Yeah, if we have seen in a few cases, but in such cases we do not wait for the case to appear the next day or the third day. We just call the patient couple and explain it to them that even if it appears or it becomes an embryo later on, it is not going to be normal. So we are not going to transfer. So in those cases, we counsel them accordingly. But we do not use those for the patients, and we do not wait for, we can wait and use those embryos for experimental purposes, not for the patient purpose.
Really, in such cases, delay fertilization with delayed development or delay cleavage, in such cases, we have no chance of transfer of the embryo.
No, but then what would be the reason here? Like, why are we experiencing delayed fertilization? Fertilization happened. Maybe the first you think IVF, something went wrong. But even if it exceeds a delayed fertilization, what would you contribute the reason to?
Again, activation problem.
Is it activation problem or any other problem here?
Yeah, activation is
genetically problem of oocyte.
Yes, there can be multiple.
Cytoplasm, yes, maybe. Maybe with the cytoplasm, oocyte cytoplasm, there was some reason. That's why the activation process got delayed. And this kind of cases I have seen 2-3 cases, maybe 3-4 cases I can remember. All those cases, maybe sometime I saw like the after 2 days you see that PN is there, and then suddenly it rises up to 4 cell or 8 cell or something like that. It goes very fast. So the kinetics is very different.
So that was my question. Is oocyte morphology prognostic of embryo developmental potential after ICSI? Do you think the cytoplasmic maturation of the oocyte also is very, very important for the fertilization here? Dr. Shrikant, I can't see you.
Shrikant, where?
Okay, Parag, you can take it. Is he there?
Yeah, he's there. Unmute.
Yeah. Sorry. Could you please repeat? I was just got my charger.
The question is here, is oocyte morphology prognostic of embryo developmental potential after ICSI? So I was asking, is like cytoplasmic maturity of the oocyte, how important is that for fertilization?
Yeah, yes. Granularity is there, SCR is there. If you see some vacuoles in that, if while during ICSI, if the polar body is very flattened or splitted, these are the few things where you can note down, like these are the eggs quality, and you can follow that growth, you can follow the best ones then. So there is a chance that we can predict a fertilization development potential with the egg quality. Yes, these 4 factors definitely is. Pitting also is there, like
Yes,
granularity of the cytoplasm.
Rag, you were saying something?
Yes, with that, the funnel formation, that is also another thing. Like,
okay.
So
the oocyte contributions to unsuccessful fertilization, there have been many papers saying that a cytoplasmic defect in the oocytes was a primary cause of couples' infertility. When if there are total fertilization failures or recurrent low fertilization, so the cytoplasmic defect of the oocyte plays a major role. Rather than oocyte activation is there, but this also plays an important role because there have been cycles where even after ICSI, after artificial oocyte activation, the fertilization was same. It wasn't better. So in those cases, maybe donor oocytes was the only option left for the couple, since we have tried everything and nothing got affected.
Yes.
So that is
Cytoplasmicity and perivetal space also play an important role in such type cases.
We can't hear you. You're not very clear.
Cytoplasmic homogeneity and perivetal space also play an important role in such cases of.
Yes, true.
Got to look into that. Yeah.
Yes. So over to you.
Now what I have to do?
Conclusion.
Share screen, huh?
Can I?
Wait, man. I have to say.
Total fertilization failure, like right inside, if you see total ICSI, then the person who is doing actually, there could be total fertilization failure. If there is damage to the eggs, that is also one problem. If there is infection,
but sir, that wouldn't be total fertilization failure. Fluke से एक दो तो fertilize हो ही जाते हैं, sir.
नहीं होता है, problem आता है. And sometimes infection also you should count on. Like if there is some problem with the CO2 levels, that part also should be
इससे पहले एक पेपर दिखाया था, उसमें मैंने SUC के करीब 25 केसेस किए थे जब मैं एम्स में था उस समय, तो वो आपने उसमें प्रेजेंट किया था इसी स्लाइड में ही.
हाँ.
So lab part, one thing you have to also take care, like if they are split cases. That's nothing else.
Okay. So that's
Amit is going to conclude the panel.
Yes, that's what. Because doing too many cases is also not good in a day. So we did 5 cases. During pandemic, we have to maintain the social distancing. Yes. So the conclusion is that
the work can be shared. You have to have your team there, not a single person works for 12 hours.
Yes. So 60% of cases of total fertilization failure occur in patients with poor matured oocyte yield. Secondly, a subset of patients with both mild and severe male infertility fails fertilization despite acquisition of an adequate number of matured oocytes and perform of ICSI. Failed fertilization is the absence of poor matured oocyte yield or abnormal semen parameters as a rare event. It's not very common. In the group we were discussing, it is somebody's Gaurav told that it is 1 in million. But for the patient, it is $1 million question.
Yes.
For us, it is 1 in million. If a patient will come to us with 100%, assurance. For us, it may be 0.001% because you may be doing thousands of cases. That is a different issue. Our data suggests that the need to evaluate ICSI criteria using sperm morphology to minimize the risk of total fertilization failure with conventional insemination. These data are important for counseling patients. It's very, very important. Counseling and convey these matters to the clinician concerned because they are going to face the issue. So you tell technically what is the issue. What is because you are not dealing with iron or wood, it is a biological material. What ICSI or IVF we have done 20 years back, the maturity or the healthiness of the oocyte and the sperm is much, much different now. So the embryologist, the instrument, everything is same, but the constant change is your biological material, which is going to decide your success. So the closing remarks is that the role of contribution of oocyte quality is successful fertilization followed by embryogenesis and live birth is much greater in art compared to the sperm. Assisted oocyte activation in all means a good alternate for total fertilization failure or lower fertilization failure. Any extra manipulation may have an adverse effect which only the long-term follow-up can reveal. Always remember that any technology introduced, it is going to be in this human race for millions of years to come. Science is a constant change and it is for good. We will use it for good. The science of art and its need is increasing so that the technology and the demand also will increase and you have to work under pressure. Anyway, happy embryology. And I thank my panelists Srikanth, Parag, Geeta Goswami and Abhinesh sir. And thank you audience. Attention is the rarest and purest form of generosity. Thank you for your generosity. And Team ihera, thank you very much from Saroj and myself for this opportunity given to us.
Yes, sir. Thank you, ihera.
Thank you so much. Thank you,
Thank you so much.
Stay
Thank you,
safe
Dr.
and be aware, because the 2020 is very, very wild. Thank you. Thank you. Let us see if any questions are there. Lots of questions, parallel discussions. Let me check.
Sudesh, there is some question. Good question. Infection or something.
Yeah.
Maybe we can just open it to audience if someone wants to ask a question or discuss something here. We have 5 minutes.
Then actually it will be very difficult.
Very difficult because
to unmute or
Okay,
mute to mute.
No, you can
So
choose.
everybody
You can
will
choose
start
the questions.
speaking.
Go through the question list. You can choose.
Yeah.
Dr. Sudesh
That is
Kamat.
better.
Is Sudesh sir there? Sudesh sir can give a light, because there's been a lot of discussion about ICSI and Sudesh sir.
He's there. He's there.
I'm making Sudesh sir a co-host.
He has
So
asked.
Sudesh sir, you can now open up your mic.
He's the right person.
During fertilization check, can we salvage the cycle?
No. He is asking about contamination post ICSI. How
Yes.
will you rescue that? But actually, contamination is not source of actual ICSI, so it can be anywhere. And rescuing in that case, we had a long discussion on baby makers group, if you remember.
But generally, contamination is seen, as Gaurav pointed out, that we see a lot of contamination. In ICSI, there are very, very few or rare cases where you use contamination. That is my this thing. What do you have to say?
Very true. Very true.
I agree with you.
Less chances.
Yeah.
Very less chances in ICSI.
Yes. Okay. And regarding globospermia, Gaurav given a clearance certificate. Swami sir, I just wanted to make clear, no AOA until you are sure about the globospermia. Please note down that.
Yes, 100% globospermia only use.
Yes, it's a clear point.
But when globospermia is there, we can give an option of donor cycle. Now, why can't we counsel the patient then?
Maybe Delhi it is not allowed.
Hi
Gaurav,
everyone.
if you are there, hello sir.
Sudesh, welcome.
Hey, you made the chat so interesting.
Sudesh,
Yeah,
warm
hi
welcome.
Swami sir. Hi. Yeah.
Guest appearance.
Come.
Yeah. First of all, I'd like to congratulate all the panelists, the speakers. Beautifully conducted panel. Very, very interesting. And Swami sir was, simultaneous. He is a king of multitasking, chats, and this very beautiful. I'll say, and even I have to give credit to Ved also.
It's a great compliment.
Yeah.
Thank you,
it's
sir.
really been conducted
Thank you.
well, because you can see all of us are interacting simultaneous.
That's what I told.
Just a few questions, because Swami, you had asked us for the panelists. What if we see contamination next day, whether it's IVF or ICSI, whichever method you do. So what can we do to salvage the cycle? Maybe this may be something interesting to new embryologists and all. Is there anything we can do?
Rajvi.
Maybe Srikant can answer. If we see contamination on second day.
My choice would be immediately washing with the fresh media, like the media which is kept in the incubator, freeze them or transfer immediately. Either of these two. Like either freeze or immediately transfer. You have to wash it, freeze it, or transfer it immediately. We can't extend them, because if contamination has occurred, it will definitely continue on next day also.
If somebody is giving any opinion?
Can I join, Dr. Can I say
something? Gaurav. Yes.
Most welcome.
Thank you, Saroj. So even a single bacteria is enough to cause the contamination, right?
Yes.
So you have to see whether the bacteria is commensal or it is dangerous to the embryo growth. So if you wash it and culture it for 2 or 3 days, and if you see a proper growth of the embryos on day 3, you see 8 cell embryos and forming a blastocyst on day 5, you can transfer it. I have seen pregnancy in those embryos. So you have to first see whether the infection is commensal or not.
But in some embryos, Gaurav, in some embryos
are actually growing, that means the bacteria is not harming the embryo at all.
Yes.
Shrikant sir, there have been cases where there have been bacteria, the infection. In the second, third day, you see the embryos are completely lysed, or they kind of open up and all that. In those cases, you cannot salvage that.
Become arrested, they become brown, usually it is recommended not to culture. You can freeze them and then you can at least transfer in next cycle or in the same cycle. Usually, at least personally, I won't recommend to culture.
Sometimes I feel it's best to discard those dishes and save your lab and save the other dishes to be contaminated. At times you feel when you see the look of it, you know that contamination cannot go by washing and everything. Maybe you should just discard it.
Yes.
I don't know what.
No,
I agree with you.
That particular media.
Yes, Rajvi. Dr. Rajvi, can someone unmute Dr. Rajvi?
Yeah, I have unmuted.
Rajvi.
Yeah. No, what I would see is the level of contamination, because if you are waiting to see that the embryos are already damaged, then it's already too late. But if you see any kind of turbidity in the medium, and that is possible when you're using larger volume droplets or larger. So if you see any turbidity, just immediately wash before you even go for culture of the culture media for microbial culture. And supposing it is damaged, then anyway it's going to break. And the bacteria don't jump from a dish to the dish. So if you are having a separate dish and you put it properly, because even when you do microbial cultures, bacteria from one tube or one plate don't go to the other.
It is a dilution again, Dr. Rajvi.
Yeah,
right?
so it's basically you're diluting it out and washing it multiple times so that you're reducing the number of.
Basically, why we are.
And you save it for the patient. Whatever. Don't go for blastosis and all, as Shrikant said, just transfer it off.
Yeah, basically, why we are worried about the contamination in embryos is that it's not developed any immunological system. It can't protect itself. So easier, better you try to reduce the viral or the bacterial load and put it back to the natural environment, which is already an immune system is present, so that will take care. This is the entire concept.
Exactly.
Other concern is that it may not do anything to the embryos, but it is
it may be good for the embryo. We think that it is a pathogen.
What Sudesh's option is there? Sudesh, what do you do in this case? What is your recommendation?
No, actually, see, because I have been doing mostly all 19 or 100% ICSI, I have not seen any contamination at all. Earlier you did.
Are you there for the ET at all? You just ICSI do. Later on you should many times.
No. See, I'll tell you as a rule, I mean, like in my center also, we check fertilization every time.
Yes.
It is not just to see the fertilization, but
in
also
that,
to check
suppose
the
if it
dishes.
happens, what is your recommendation? If at all it happens, what is your recommendation? What is your
supposing
view
it
on
happens, you have to first see whether it is, you have to first of all check the dish every day. You have to see whether it is bacterial or it is fungal. If it is fungal, you can easily salvage it. It doesn't damage the embryo much. You have to keep on washing. Bacterial, next day, if you see there is some growth, some white turbidity, powder like it, you have to keep on washing it. You have to do everything to salvage that cycle. Keep on washing. There are papers, earlier papers, I think some 15, 18 years back, they have been washing the oocyte embryos every 2 hours, 3 hours, multiple droplets. And they have found that, sometimes what we would recommend is, use different media. Nowadays, we have media with gentamicin. So
very good 5th generation medias,
So you hardly find any contamination. Earlier, when we used to make our own media, penicillin, streptomycin, there would be infection when we used to do IVF, maybe through the semen sample or our techniques were not good. So we would wash the oocytes, multiple medias, like if you have 2 different culture medias, we'll try to wash in different media. At least some antibiotic will take effect. And then you have to just think, I don't think media is to be blamed. Nowadays you get excellent media. You have to see your technique, whether your pipette is touching somewhere. That's the only source, because semen also nowadays, most of the centers do all infection tests and all. So there's hardly any chance of getting from the semen.
Culture they do.
I wanted to ask one question here. Whoever is using time lapse here, have you ever seen this kind of contamination time lapse?
Same question I want to ask.
We have been using. We have never seen any contamination, and not just time lapse. So what we do now, what others I would recommend, supposing you don't have time lapse, what is the whole concept of time lapse? We have around, say, in one dish, you have around 12 wells. You can put each oocyte in one well. So that is what we do. Instead of putting.
But doesn't that one well contamination go to the 12 wells? I just wanted to ask that.
It doesn't go.
This doesn't happen. This doesn't happen.
Even the infection, like as Dr. Rajvi also mentioned, it doesn't jump from your dish to dish. If your media is contaminated during handling, it will go to all the dishes. That is because in transferring the media, somewhere the pipette is touched. That is why your entire media is contaminated. It won't jump from a dish to another dish, even in your regular incubator. So what we do, just like time lapse, where you don't have a time lapse, we make droplets, and we put only one oocyte each droplet, and we number that droplet. We try to follow it. Of course, we try to minimize exposure also, but every day we follow. And then we that way we select, because we also do all blastocysts. We try to select which is the best embryo seeing it, you know. Okay, day 3, this
But
was 8
sir,
cells. Day 4,
I think we can even say that earlier when we started embryology, maybe 10 years back, what Swami sir has just written, things have improved a lot, the age, the media and everything. I don't see contamination, like I haven't seen contamination for quite long right now. Earlier, maybe, you know, there were 1 or 2 we used to see, but haven't seen contamination since long now.
Yeah, we have also not seen any. Yeah, please.
GLP is the important one. Yes. GLP is important, so there won't be any infection.
I have a question. I was approached by an embryologist for troubleshooting, and she had unexplained infertility, half IVF, half ICSI. And IVF embryos did well, and ICSI on day 2, she found contamination. So she washed umpteen times, you know, the usual thing that we do, but there was increased turbidity. IVF embryos went well, and they went up to blastocyst. And it was the opposite of what we generally conceive.
Yes.
Because
So
we don't really expect.
So maybe the
So I only think
PVP or some media, some PVP, some media, or maybe the because
maybe some petri dish.
Yes.
Maybe,
while we do believe that IVF is the primary source, we need to keep in mind that ICSI also can give contamination.
Can be, yes.
Who is doing
any,
ICSI also
any
important.
method can give, what Swami sir said is very important. You know, maybe when injecting, you know, sometimes, you know, there are some embryologists, you know, who may just try to fool the clinician. Suppose the oocyte is damaged. You may say, okay, it's infected. That's why it's got damaged. All this can happen. You know, but what you said, who's doing is very important.
So this case, the clinician herself was doing the embryology.
Then you got the
But that's more to the reason, ma'am. More to the reason.
It's not like
Many
that.
people,
So
you
there
know,
are-
they
Is
suggest
usually, as
you-
Saroj said, right? It is old PVP or maybe some flexiped touched here and there.
Correct.
Flexiped touching here and there or PVP. There is nothing else in that.
So basically, it is handling. It is nothing to do with
the air quality of that particular lab, because the
air quality what?
No, air
But
quality will
IVF
affect
was
everything.
okay, no? Why will the
IVF was okay.
IVF was okay, no?
So that was not, you know, exposed to the outside of the laminar flow, na? During ICSI, but that might have exposed to the normal air of the lab.
No, but ICSI is done under
But
oil.
even IVF, Parag, when you denude after IVF and everything, I don't think that's a lab issue
Oil
here.
also can attract contamination. That is not the issue.
Because there is
I like to ask
I
the
think-
panelists, all senior embryologists, how often do you find contamination in your own lab, whether it's IVF or ICSI? Do you find it more in IVF, less in ICSI? To the panelists, even Dr. Ved can answer, you know. Because I don't
in
find any
IVF,
contamination.
IVF, I think we can get the infections. Sometimes
yes,
I do
I
find
agree.
that in IVF, but in ICSI, not even one I have seen. But IVF, definitely, sometimes I find that there is infection, some haziness, turbidity in medium. But where the eggs are there, only in that particular drop is turbidity. In other drop, there is no turbidity. It means there may be some infection with the egg during the collection. We have done something wrong with that, or sometime maybe preparation, we have done something wrong in that case.
But can I say something here? After attending so many years of ACE conference and listening to everything, I think the quality control of all the labs have improved, and that's why we are not getting contaminated.
Yeah, you're right. Yeah, you're right.
Very true.
Yeah, you're right.
Because we are learning so much about quality control in the last few years. I think everyone has become quite, the quality control, the SOPs, everything. People now take care of it. Earlier, it wasn't taken care of, but now everyone is very, very careful about it.
And,
right.
After this pandemic, there won't be any kind of contamination. So scared of handling
contamination. How do we handle?
So I think now we have to conclude, and it was very nice discussion.
Thank you,
and
Sudesh and
Thank you,
with that,
sir. Thank you for having us over.
We have to join another meeting again. We have more
Dr. Rajvi, Dr. Sudesh, thank you for your inputs all the time.
Rajvi, nice presentation. I have 2 questions. I'll send you personally also.
Okay.
I'll keep bothering you.
Dr. Ved, just share the Facebook link, no?
Yeah, we will share. And so thank you very much to all of you, all of our moderator and all the panelists, and of course our speakers also. So there is one more webinar upcoming that on 15th September 2020. It is on IVF conventional versus unconventional. So it will be more, much more interesting, and there will be Dr. Priya Kannan and Dr. Sarabpreet is going to moderate that session. So do join that. And one more announcement again, we are going to happy to announce first International Symposia experts meeting for the best practice in clinical embryology, MBART. So please block your dates 2nd and 3rd October. It will be full conference from 10 to 7. And pre-Congress master class will be there on 2nd October for 4 hours. So please join that. So block that date 2nd and 3rd October. So see you again.
Thank you.
Okay, sir.
Thank you. Thank you. Take care.
Thank you, sir. Thank you, everyone.
Take care. Bye.
Thank
Bye.
you.
Well done. I have my divisional head with me. Rajiv sir, you are a co-host. Can I ask you for a vote of thanks? Rajiv sir.
Yeah, thank you, Dr. Amit. On behalf of MSC Limited, I just thank Dr. Ved Prakash for initiating this wonderful webinar, and I thank all the eminent speakers and all the panelists for a wonderful webinar. This is our 100th webinar, and we are very proud as a team. Entire credit goes to our team for spreading the science in this pandemic. And MCure is always a preferred partner to various societies. We thanks to societies and thanks to Dr. Ved Prakash to be the part of this series. We'll meet you again in the next webinar.
Thank you.
Time I wish all very safe and healthy life. Thank you very much, sir. Thank you all.
Thank you so much.
Thank you. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you.
Bye bye, sir. Shrikant sir, Ved sir. Thank you.
Bye, Swami. Bye, Ved.
Bye.